Thank you, Gary. Thank you for inviting me to present tonight, and thank you all who are attending. Tonight I will talk to you about what I know about pediatric scoliosis, and my partner, Dr. Singh, will discuss the aspects on adult scoliosis. So firstly, let's look at what we would normally call normal spinal alignment. Normal alignment is what we call a normal cervical lordosis, usually around 20 to 40 degrees in the cervical spine. There is also a thoracic kyphosis, which means we all have a degree of kyphosis, usually between 20 and 40 degrees. Some would say up to 50 degrees in some studies. So anything higher than that degree of kyphosis, we would say that there is a abnormal degree of thoracic kyphosis. And then there is a normal amount of lumbar lordosis. And lumbar lordosis is important because, as you see from this diagram, for us to stand up nice and straight, the lumbar spine has the most amount of lordosis, meaning the spine bending backwards, to align our center of gravity with our sacrum and with our legs. So as we get older, if we lose a little bit of this lumbar lordosis, we then start to stoop forward. But that's mainly an adult spine. What I'll talk to you a little bit more about today, and I'll leave these other discussions to Bisham later on. Firstly, I'd like to talk about scoliosis. What is scoliosis? Scoliosis is essentially a curvature in the spine. When you look at the spine from the front or from the back, a normal spine should essentially have a straight alignment. It should be a straight line. If, for whatever reason, there is a curvature, or sometimes more than one curvature, then that is what we call scoliosis. How do we measure it? We usually measure it by drawing a line parallel to each of the vertebral bodies, and then essentially you'll measure the two lines that makes the most angle. So it's very simple. If you don't know which vertebra to take as the proximal one or which one's the lower one, all you need to do is draw a line at each and every level, and then you'll be able to measure the two lines with the largest angle. And that is essentially what we call the Cobb angle. Now you need at least 10 degrees of Cobb angle before we are allowed to call it a true scoliosis. And what that means is, on a day-to-day basis, we would stand or present for whatever reason with a slightly lean to maybe one side or another. Maybe it's muscle spasm or maybe something else. But normally you need more than 10 degrees of a curvature before we would believe it as a true structural scoliosis. The other part of the scoliosis definition is also, besides a curvature that you can see on this CT scan, there's definitely a curve in that spine. You can see on the axial scan of the CT scan that the vertebral body is actually also rotated. So this picture here, C, it doesn't have any rotation. You can see where the spinous process is pointing up and down. But the slice that's taken through B, you can see the degree of rotation is significant, and also along A as well. So the important part is scoliosis is not simply a side-to-side tilt. There is also a significant rotational component, which brings me to the next point is, when we have a rotation of a straight column, what will end up happening is a asymmetry of the shoulder So one side of the shoulder will be higher, and also there will be asymmetry of the rib or chest, because as the spine curves and rotates, one side of the ribs or the musculature will be higher than the other. And the way to see that, and I'll show you later on, is a simple bending test where you ask the patient to bend forwards. So there are different types of scoliosis in the pediatric population. The most common type is the idiopathic, where we do not have a clear explanation of why they have the scoliosis. Basically, we exclude all the other causes, and if they are excluded, then what we call them idiopathic. Neuromuscular curves, such as cerebral palsy, congenital curves where there is a malformation or extra vertebra on one side causing a development of a scoliosis, and syndrome where it may be associated with a particular syndrome like Down syndrome, Prader-Willi, and different types of syndromes often cause muscle imbalance and often cause neurological symptoms that cause scoliosis as well. So these type of scoliosis that's listed below are not truly what we call a structural scoliosis. So they are postural or sciatic or pain related. So when you have a degree of pain, you will have some muscle imbalance, and therefore you'll tend to have a lean to one side or a curvature in your spine when they take an X-ray, or if you look at the patient. When we talk about a non-structural curve, a non-structural curve is also what we mean by it's not caused by any of those particular types of scoliosis. A compensatory curve means that it's often below or above a structural curve where the spine has to bend the other way for the patient to stand up properly. And there is another type of scoliosis which is not true scoliosis, is when they are caused by what we call pelvic obliquity, meaning that the pelvis is not entirely even, and then and that could be also caused by a leg length discrepancy when one person has one leg longer than the other. So far the two key points are, for a curve to be called a scoliosis needs to be at least 10 degrees on measurement, and also there is a three-dimensional component to it, and in particular you need to pay attention to the rotation. Now, the difference between pediatric and adult or degenerative scoliosis is separated into these two things, but most importantly, the difference is not just for age. Age is obviously a given, but the maturity of the patient. So whether the patient is still growing and how much growth they have left, whether they've started their menarche, meaning they've started their periods in the female patient. So the menarche is a way for us to estimate a person's growth, and I'll show you some growth curves where we use that as a measurement of growth. The other important part between pediatric scoliosis and adult degenerative scoliosis is the size of the curve, because the size of the curve is both prognostic, along with the maturity of the patient, and also it tells us whether the curve is more likely to progress over time. And of course, family history plays a much larger component in pediatric scoliosis than adults. So there's approximately 2 to 3% of the population is at risk of scoliosis at any particular time. And this is a population up to the 16 years of age for pediatric scoliosis. And you can see here it is much more common to have females to have pediatric scoliosis, and the ratio is almost 4 to 1. So it's much more likely for a female to present. So therefore, we are a little bit more wary when we see a male patient with a substantial scoliosis. And these are the patients we often obtain MRI scans and investigate a lot more in case they have the other types of scoliosis. Now, when you see a patient who has pediatric scoliosis, the important things to ask and important points in the history are usually how was the curve detected, and also how soon or how recent was that detected. Often you'll find that over the summer months when the child is in swimming gear, or if they do like dancing or different types of sport where posture is particularly important, somebody will notice that there is a difference in their shoulder blades or shoulder height that then brings attention to the scoliosis. Pain is an important part to ask, although pain is not usually associated with scoliosis. And in fact, if somebody presents with a significant pain history, meaning a continuous amount of back pain in a child, we actually take that quite seriously, and we actually investigate that separately to the scoliosis, because as a general rule, pediatric scoliosis does not cause pain. So scoliosis itself is not a good enough explanation for a pediatric patient to be complaining of pain. And we'll discuss that a little bit more. I think that's a very important point. Ask about neurological symptoms. Ask about respiratory symptoms as well, because we know that curvatures that reach 60 degrees or above, you start to have a degree of compromise of your lung function. So exercise history and respiratory symptoms are important. Any family history of any neurological disorders, and also history of scoliosis. And also ask about status of growth, whether they've grown a lot recently, whether they've changed their shoe size, menarche, a few other things, and clothes sizes are the things that we generally ask about. And also we usually ask them to stand up next to their parents to see where they are compared to their parents in terms of estimating how much growth they may have. So these are the types of asymmetries that you may notice on a patient. The diagnosis is suspected by maybe a difference in their shoulder height. Maybe one scapula is more prominent than the other. Maybe there's a difference in the chest prominence, either in the front of the chest or the back of the chest, and also whether there is a tilt in the pelvis, whether making it a suggestion of whether there is a leg length discrepancy. And of course, neurological examination is very important. And this is the what we call the Adams forward bending test. In a normal spine, or in any spine that doesn't have a structural scoliosis, so if they had a sciatic scoliosis or non-structural compensatory curve, when they bend forward, it will be even from side to side. But when they have a structural curve, when they bend forward, you would accentuate that rotation component of the scoliosis, and you'll be able to detect the ribs on one side higher than the other. So that's a simple test you can do in your office, and particularly when these patients come with their siblings as well, you can get them all to bend forward just to see whether there's a family hereditary component to that as well. Now, we also have the important part of pediatric scoliosis, also assessing skeletal growth, and because that tells us what the risk of progression is. And we'll talk a little bit about how to assess growth. One thing we also use quite heavily is parental height. We also use normalized growth charts. Menarche is important because once a child starts to have their periods, they start to decrease in growth velocity. So leading up to the point when they're having the periods, they're actually growing very, very, very quickly. Once they start their periods, they are still growing, but the velocity of the growth is usually starting to dip. So therefore, that gives us a good indication. And generally, we feel that when a child starts to have their periods, they would generally slow in terms of their growth to about, and we usually quote about 12 to 18 months of growth left. The other important part of the pediatric curve in terms of prognostication, in terms of besides the maturity of the patient, is also the onset of the curve and also the curve magnitude. What does that mean? That means that the younger the patient presents with the scoliosis and the larger the curve when they present, they have a much higher risk of that scoliosis progressing. So what does that, let me put that in another way. If a 14 or 15-year-old comes in and the curve measures around 20 or 30 degrees, that child is towards the end of their growth or probably have ceased any further significant growth. So that curve has a much lower chance than if that same curve presents in a child, say 10 or 11 or before they start their periods. One of the ways we also assess bone age is to a hand x-ray, and there's atlas and different ways that we assess the growth placed in the hands that gives us an idea of where the patient's bone age, meaning how much skeletal growth they may have compared to just their simple age. Because the textbooks would say that in a female, they may grow until they're 14. The old textbooks say that the boys will grow until they're 16, but obviously there is a great deal of variation. And one of these atlases that basically documents the different ossifications of the carpal bones and the interphalangeal joint growth plates gives us an estimate of where that patient is in terms of their growth. The other one that we use in terms of estimating growth, and one of the other reasons why when we ask for x-rays of the spine, we like to include the hips and the pelvis as well, because one of the earliest signs that we use in terms of estimating growth is that little bit of cartilage, a little bit of growth plate that you can see. It's a line just above the pelvis on the iliac crest. And depending on where that line is growing, how far across that is, that tells us how much growth they may still have in terms of the patient's growth. So if that line is completely grown across, we think that they've got very little growth. But if you don't see any line at all, then they're very early in terms of their growth phase. The other things we look at in terms of estimating growth is the triradiate cartilage. So when we look at the hips, we look at the acetabulum, and that acetabulum is formed by 3 different bones joining together to form the acetabulum, and that's why we call it triradiate cartilage. And usually that would start to close around that age 12 or 13 mark. So if you see a patient with the triradiate still open, you know that they still have quite a lot of growth remaining. Other estimates that of age we use is also the elbow. And why do we spend all this time trying to estimate the patient's growth is basically comes down to risk of progression. The larger the curve and the higher the risk of growth, such as a risk sign of 0 or 1, even a mild curve would have a much greater risk of the curve progressing. So why do we want to know that? We want to know that because we are now thinking of what we can do to treat the patient. So if a patient is sick, is immature, premenarchal, and has a small risk sign, female sex, the rate of progression is much greater compared to a more skeletally mature patient. So in terms of treatment, what do we do? I'll talk about treatment in a second, but thoracic curves, if they end up around 30 degrees, they are fine. So at skeletal maturity, if they're only around 30 degrees, they are normal in terms of their future activities as an adult. They've got no more or less back pain or any other back problems as the general population. If it gets to 50 degrees, then they tend to progress even as an adult. So that's why we tend to treat most likely surgically at 50 degrees, but anything less than 30 degrees, we tend not to treat. Lumbar curves, if it's less than 30 degree at skeletal maturity, they're usually okay. Once they get over 30 or certainly around 40, those curves we are more anxious in terms of treating because the lumbar spine is a lot more mobile. So a larger curve will tend to give a person more problems as they grow older, and the progression is usually a little bit higher as well. Genetics plays a part as well. So if the patient has a first degree relative or second degree relative that has scoliosis, they will tend to have a higher incidence of scoliosis, but also they often have a more aggressive type of curve. They tend to have curves younger in terms of development, and the curves tend to get bigger as well. So key points: younger the patient, higher the risk of progression. So look at referring early. Estimating maturity, if they are already mature and they're fully grown and all the signs show that they're grown and the curve measures 30 degrees, you can reassure them, usually will not affect them whatsoever in the future. But important thing is to get proper x-rays, get full spine x-rays that see the whole spine in the one picture. The x-rays that only show the thoracic spine, the lumbar spine, the angle of projection of the x-ray is different. So when you measure the x-ray, you can get a different rotation of the spine and therefore a different measurement. So we now tend to order the EOS scans, which is a low dose radiation scan, and also you get AP and lateral fluids in the one scan as you perform it. So what's the natural history of pediatric scoliosis? Back pain, well, they do have some, but it's not actually related to the magnitude of the curve. They are comparable to the general population, particularly curves of less than 30 degrees. Cardiopulmonary dysfunction usually doesn't affect their cardiopulmonary function until the curves get larger than 60 degrees. If the curve is untreated and it reaches more than 100 degrees, it has in the old days been described. You can get restrictive lung disease, and you can get cor pulmonale, and you can get heart failure from basically too high pressures in terms of pulmonary pressures. Natural history with respiratory function is if you have less than 60 degree in the thoracic curve, then usually you don't have a problem in terms of lung function. However, once it gets 260 and above, then you start to have perhaps up down to 1/3 or 1/3 less than your normal lung function. So the curves left in these sort of 100 degrees or 80 degrees curves, they tend to develop problems later on. So these days we then tend not to leave it any curves more than 50 degrees and sometimes even 45 degrees. Mortality only if it's really large and more than 100 degrees. But most commonly when we do any surgery or any treatment for scoliosis, cosmesis is actually the major concern, and the psychosocial effects in adolescence is quite significant, particularly in girls. Boys don't verbalize it as well, but in our studies we have seen boys and girls and teenagers particularly worried about their appearance because of scoliosis. So treatment, well, it depends on the curve magnitude, how big it is, depends on how much growth potential that the patient has. Less than 20 degrees, we just observe and we get further x-rays. More than 45 degrees, then we tend to start talking about surgery. In between, if someone reaches the say 20, 25 degrees, patient who's very young and still lots of growth remaining, we'll start talking about bracing. So bracing is still commonly used in those patients that has not reached the surgical threshold of surgery. In the thoracic spine, that would be 45, closer to 50. In the lumbar spine, it'll be about 40 degrees that we tend to talk about surgery. But in those patients that are not quite to that degree, then we would offer them a brace. The braces, there are different types. This is a type that we tend to use at the Children's Hospital, and we've been using it for many years with good success. It's a thermoplastic molded brace. The patient wears it all the time, including going to bed, except for showering, playing sports, and basically general play. They basically aim for 20 hours out of 24 to be wearing that brace. The Milwaukee brace that comes all the way up the neck is really difficult to wear. Very few patients are able to wear it just because it's so cumbersome. These are mainly to treat kyphosis and curves that are above the T7 level. But again, the compliance is very low in terms of, because it's quite cumbersome, and that's a more historical type of brace. We call them Milwaukee brace. The thoracolumbar orthosis or Boston brace is the one that we tend to use, and it treats curves that are below that T7 apex. There are exercises that people do for scoliosis. One type of exercise is called the Schroth exercise, and they have been shown to give short-term improvement in terms of the spinal rotation, but in the longer-term studies, it hasn't shown that it really prevents progression in scoliosis. So while exercise is great to do, it's not yet the mainstream that we send everyone for Schroth exercises as yet. So one question I'd like you to think about is, say, if you have an 11-year-old female presents with a 30-degree scoliosis. She is premenarchal and is shorter than her parents and her 12-year-old sister. How should she be managed? Would you review in 12 months? Would you send for chiropractic treatment, refer for blood tests, or refer for bracing, counseling, and 4 monthly x-rays? The answer is D, and that's what we tend to do. Once the curve reaches the surgical threshold, which is usually between 40 and 50 degrees, then we start talking about surgical treatment for pediatric scoliosis. And there are different types of treatment, either fusion or limited or non-fusion techniques, and there are different things that we do. In young patients where we really don't want to fuse their whole spine too young, because they need a certain volume in their chest to allow lung development and alveoli development. So there are different techniques that we use. This is what we call a growing rod construct, where we only fuse one segment above and one segment below, but in between we have rods that slide, and we periodically, every 6 to 9 months, we go in and we lengthen the rod so that we allow the spine to lengthen while the rods support the scoliosis and stops it from going out of shape too much, because the bigger the curve, the harder it is to correct later on. And you can see in this very young child, it's only 6 or 7 years old, it is quite a large curve. And we used a traditional two-rod growing construct, where this is a part that we would go into every 6 months, just a small incision here, and we would lengthen the rod to gradually allow the spine to grow. And then when they get to a certain age where we think their growth has achieved at least enough growth in their chest volume or chest height, then we would consider fusing it as a definitive final surgery. So this is the patient over time gradually having rods lengthened. We also have a magnetically controlled growing rod, where we place 2 rods in there, and there is a mechanism in here where we are able to put a magnet as an outpatient on top of the skin, and the mechanism are able to turn that mechanism inside that allows that part of that rod to lengthen. So that has really revolutionized how we do some of these really young children with scoliosis, so they don't need to come back for surgery over and over again. The other type of surgery is what we call fusionist surgery, where we basically enter the spine, access the spine through the chest wall, and we put these screws into the vertebral body, but with a flexible band or a rope type construct that basically tethers on one side and allows the other side of the spine to grow to decrease the curvature. This type of procedure still has a fairly high revision rate or repeat surgery rate, so up to about 20% or 30% of patients need further surgery. And also we are finding that the control of the curve in terms of the cosmetic control is not quite as good as doing a fusion in terms of cosmesis. So it's still a work in progress and something we're still studying. The traditional way that we've done since the 50s is the fusion, where we measure the curvature, where the Cobb angle is, and in this case, this is the major curve in this part of the thoracic spine. This is a small compensatory curve above and below, so all we need to do is fuse that middle section across that main curve, and you can see that the curve is well corrected, and the cosmetic improvement is significant, and also the patient can go back to doing more all sports and even professional sports. So this is the type of instrumentation that we use these days. We put screws. We may put also these sublaminar bands underneath the spine, underneath the lamina as well, to hold on to the spine. And then we would place these rods. We will put the rods after the screws go in, and using the screws as the anchor point, and using the rod, using different strength of metal of the rod, and bending the rod and securing the rod to the spine, we can derotate the spine to achieve the correction that we want to achieve. So I will stop there. My time is up now. So that's actually a very good question, very common question that I answer for parents. And we actually have done studies in large populations of school children carrying school bags, and it does not cause scoliosis. But I do recognize school bags are quite heavy these days.
And actually, does any physical activity impact this in terms of some of the activities that kids do when they're younger?
No, so there is nothing in particular that one need to avoid doing. There's no activity that causes scoliosis. It's really an intrinsic, either a genetic or either something neurological or some of those other causes that brings on scoliosis. Otherwise, it's what we call idiopathic. So it's not a cause that we have any explanation for. So don't have to be worried. Sure, when your child has scoliosis, you are worried, but but you haven't done anything, except maybe in your family, your genetics may have that gene that does occasionally manifest in scoliosis. But obviously, if you yourself had scoliosis and a sibling or an aunt had a scoliosis, then that certainly would bring on a little bit more risk of getting scoliosis or having scoliosis manifest, and that would be something that I would ask people to just keep an eye on it. Just do a little bend test and just see a GP and have that looked at.
Terrific, thank you very much. Do we have any more questions? I don't see any just yet. No. Okay, thank you very much, Dr. Hsu. Our second presenter. Oh, here we go. We've got two more questions.
Is there restriction on sports activity for children with scoliosis? No, none at all. So there's no restrictions on sport. You can do whatever sport you like. Even after surgery, it's really the first 3 months that we limit their sporting activities, but otherwise no limits whatsoever in terms of their sport. Even those with bigger curves, like 50-60 degree curve, their curve is stable, so they don't need to be limited in any way. And the next question, does scoliosis develop into osteoporosis? No, not at all. So it's actually the other way around. In osteoporosis, if you have osteoporotic fractures, then you may fracture and start to cause sort of tilting on one side, and Dr. Singh will talk a little bit more about that as well. But scoliosis itself doesn't cause osteoporosis. It's usually the other way around.